My name is Nirvana Manning. I serve as the chairman of the Department of Obstetrics and Gynecology at UAMS, and I'm also the service line director for Women's Health. I am a practicing OBGYN, and probably about 3 years ago kind of got into this advocacy women's health world, and I don't think really knew what I was getting into, but now I'm so deep in and can't find my way out and love it. So appreciate you all here, appreciate kind of the conversations, and then I hope you will gain a lot of perspective, at least from the provider side of things. So I'm just going to kind of start this off with a really broad question so that everyone can introduce themselves and kind of give their perspective. But we've talked about a lot of things. We've talked about different access, different, issues with relation to why maternal health care right now in our state is less than what we want it to be. What, in your opinion, is needed to improve maternal health care?
So hey everybody, I'm Sarah Beth Askins. I'm a certified nurse midwife and women's health nurse practitioner with Baptist Health in Fort Smith. And a pretty obvious answer for me for this question is incorporating more midwives into our obstetric care and our well woman care throughout the state. And I think we're on the right track. We're getting there. We have the midwifery program coming to UAMS and really supporting those graduates when they start coming out into the clinical environment, making sure they have preceptors available, making sure we're not having to send them out of state to work or to learn. We want to keep our Arkansas educated midwives in state working, and that's just going to continue to help improve our maternal outcomes.
Hi, my name is Mary Pat Hardman. I'm a OBGYN here in Fayetteville. I work at Her Health at Washington Regional. I also serve as the labor and delivery director at Washington Regional. Obviously, there's lots and lots of answers to this question, but I feel like definitely just improved access to care in general. In Northwest Arkansas, we have a super wide range of incomes and abilities and access, but we cover lots of rural counties that are, even though we are a more urban area, we provide care to a lot of rural counties. And so I think access is a huge issue, and just education and information getting out to some of these smaller areas and some of these underserved populations, that there really are some methods to help them pay for their care, but they just need people to help navigate all of the red tape in order to get that appropriate care, which is not always easy for someone who English isn't their first language or lives out in a very small community and has trouble getting to a bigger facility. There's just a lot of red tape in order to get good care.
I'm Serena Pearson. I'm also a general OBGYN here in, I guess, Johnson or Springdale is technically where I am, but Willow Creek Women's Clinic. And Dr. Hardman took my answer, kind of, but I would echo her sentiments that, we really do just need to get into these communities, the Marshallese community, some of the Hispanic population. I think they are, and Caucasian people too. It's not just those communities, but also the people in smaller towns and more rural areas. They need to know that they just need to get to us and at an appropriate time in their pregnancy, so that we can start their care at an appropriate time and not have them waiting for Medicaid approval before they come see us in the first place, because then we're kind of behind the ball, and we can't. It's hard to catch up if you present for care at 34 weeks and you've got a complicated pregnancy.
To it. My name's Dave Deschamps. I'm a maternal fetal medicine specialist. I work at the Perinatal Center. We're up in Rogers, but I cover patients for pretty much all of Northwest Arkansas, the River Valley, parts of Oklahoma, Missouri, and some from Kansas as well. I trained at the UAMS. I used to be a computer programmer for Walmart. There's a whole story there. It's a thing. To the midwife point, it's interesting. They all have my phone numbers now, which is awesome. And essentially, I'm an encyclopedia of all things complicated pregnancies, so I just try to make myself available for phone calls from anybody that wants my phone number, honestly. I thought about this question a lot, because I think that was the first question on the thing, if there's one thing we could do. And I know this is weird, but just remember I'm a computer programmer from my background. And many of us have this problem where if you send a referral or someone shows up in the middle of the night to your labor and delivery and they're from somewhere else, you may be 3 or 4 days with zero data on that patient, because electronic medical records, if you guys don't understand, require somebody to print out and then fax the records to somewhere else during business hours. So if you imagine a high-risk patient or a patient who's sick, who's coming to the hospital in the middle of the night, and this is everybody, this is every hospital, this is every provider, this is ER physicians, family practice physicians. They are asked to take care of a sick pregnant woman who has made it to the hospital. Access to hospitals is a whole other question, and then they get to guess everything about their history, no prenatal labs, no ultrasound reports, nothing. So if there's one thing that I could fix, and I have thought about this along, is an information interchange for EMRs. Rather than faxing them, we need to be able to electronically have access to them, as well as the patients on a mobile-enabled app, so they can just say, here's my stuff. I've thought about this a lot, especially because I get referrals, and it's hard for me to get records a lot. I think it's a huge barrier to care from a provider standpoint. But I think patients, to them, it's frustrating because they're like, I wish I could tell you what my doctor told me or what they were telling me and why I was supposed to come to the ER. I just don't know. They just told me to come. So that's a deep thought I had last night.
So I'll kind of echo what everybody else has pretty much already said, but my name is Shannon Case. I'm a general OBGYN in Clarksville. So I'm in a rural setting where about 51% of our OB patients have Medicaid of some sort, either primary or secondary. So we take care of a very low socioeconomic group of women. I share call with family practice physicians who are also providing OB care. So I have a little bit different perspective than some of the other people on the panel as well. So I've also thought about this a lot. And so everything that Dr. Hardman said about education and access to care, but also I would say part of that, not only educating patients about what to expect during pregnancy, what's important for nutrition, those type things, but resources for transportation, how do they find resources for transportation, and also where are their OB providers. I had an example of a patient just a few weeks ago who showed up to our hospital on unassigned call, and she was kind of flabbergasted that we provided OB care at our hospital, and she said, I had no idea that you guys were even here, and I literally had an emergency and Googled closest emergency room, and that's how I found you. And yet we've been providing OB care in Clarksville for many, many years. So I think education, not only about what's to go on in the pregnancy, but like many of you guys have said, where do I find those resources and how do I go about accessing the resources that I have? But also, how do I know as a provider when new resources come my way? For example, when Medicaid changed that they were then, now covering mental health services, I didn't know about that for a while. And so my office staff, even though I'm a hospital-owned practice, we were still assuming that we can't refer people out who have Medicaid for mental health services because, well, Medicaid doesn't cover that. And that had changed a couple of months previously, and we didn't know that. So I think education and communication and like events like this that open up communication with everyone are really important.
Okay, that's perfect. Thank you, guys. I am going to touch on something else because I think you guys offer such unique perspective. We talk about maternal mortality and these never events, these events that are obviously change a woman's, a family's, a community's life, in addition to the morbidity that kind of happens in these communities. Quite often, and from these different perspectives, these look very different. I think it was Representative Lee Johnson that talked about this network that we would love to create with regards to how to get patients to the next best place, right? At UAMS, we're a tertiary care center. We take transports from around the state. But when our beds are full, our beds are full. And so what does that look like from your provider standpoint when you guys have a patient that that the resources are no longer there. And I think Mabel, I think it was on the Voices panel, wanted, every hospital to have all the equipment. While I would love that as well, the realistic part is that some hospitals are really large and deliver thousands of babies a year. Others deliver 40 and 50, and so there will be discrepancies. So how can we get these moms at very critical times to the next best place, and what does that look like for you guys? And Shannon, I'll put you on the spot real quick.
That's okay. I've got lots of answers to that question. So I was actually excited to hear Dr. Johnson talk about the trauma system, because I feel like if we could have an OB system that functioned similar to that, that would be great. So again, I feel like I have all the examples, but not that long ago, I had a patient so we also have a level 1 nursery. So we have family practice physicians who provide our pediatric care, and they do an excellent job, but we are also a little bit more limited in what we can provide than some of the other hospitals around us. So occasionally, there's a little bit of pushback when we are trying to send someone who is 35 or 36 weeks. That's met with a little bit different perspective than someone who's trying to transfer, because they're like, why are you trying to transfer me? Someone who's 35 weeks, like, well, my situation's a little bit different. All that to say, I called 4 hospitals that night to try to get someone to take this patient. And so I think if there, like you said, there was, again, it was just because you guys were full, and then Baptist was on diversion, and everyone was like, we can take them, but we don't know when. Well, that's okay, but the longer she sits here, the more she's gonna change, and the less opportunity I'm gonna have to get her out of my hospital. And there's data to show when mom and baby are transferred together, outcomes are better than if we deliver the baby at our hospital and then transfer the baby. So we try really hard to transfer mom while she's still pregnant, if at all possible. So I think a central phone number where we could call, similar to the trauma line, where we could say, hey, this is what I have. I'm happy to send them to whoever's willing to take them and who has a bed available. And if not, can you give me advice on what I should be doing while the patient's here in my care?
Just helping those providers around the state such that that burden is taken off of them. They can go back to practicing and taking care of those patients, and someone can help find, again, the next best place for those patients to go. I think that's great. So as we talk about gaps in the community, I get a question at UAMS, every year, who do you have graduating? How can I get them into my rural community? What do you think the gaps are in getting OB providers or any providers into some of the communities with which you guys serve?
I mean, I can start from the midwife perspective. I mean, we are kind of in a similar boat where there's a shortage of obstetricians, there's a shortage of midwives. And so when you're looking at, I was a new grad coming out of school. I had labor and delivery experience prior to becoming a midwife. And so when I was looking at places to work, I didn't really feel comfortable working in an environment where I was going to not have those resources to rely on. And I think new grad physicians feel the same way, that you don't want to necessarily set yourself up for failure by going into a place where you don't have the support of seasoned physicians, other practitioners with you, and that extra layer of like, hey, I'm not quite comfortable here, this is what I'm thinking, that kind of collaborative practice. And so when you're looking at the rural communities, you really need that like bed of support that sometimes is just not there. But when I chose my position, moving from a large metropolitan area, moving to Fort Smith, being one of the first and the only midwife in the area, really utilizing other people in your community, not just within your specialty. So like working with family practice, we work very closely with the UAMS family practice, and having that support is invaluable. And so making sure that in your community, when you are trying to attract new providers, that you're able to highlight that support. It's like, well, yes, you may not have 10 physicians to pull from, but we have this other great, like more creative solution to that support.
I would say living in Northwest Arkansas, we have a little bit of an advantage of recruiting providers as opposed to someplace like Clarksville, like Shannon has. So we don't have as big of a disadvantage recruiting general OB-GYNs, but specialty-wise is still difficult, and we still need a lot of specialty support for women's health in general. Our hospital has trouble recruiting a new GYN oncologist or a new reproductive endocrinologist, and it's just there's still a shortage. And while we all know that Northwest Arkansas is great, not everyone from around the country realizes it. And so part of it's just learning how it just takes a while to sell it and find the right people that are the right fit for your area.
It kind of reminded me of two things. When I was in medical school, there was a rural match program, but it was for primary care, maybe general surgery, and I think it would be OBGYN, but extending things like that, where it incentivizes a program, or it would be a community essentially says, we'll help you pay for medical school if you come practice in our community. That was essentially what that program is, and that was at UAMS. And Oklahoma had similar setups. I trained there for residency and fellowship. But it is hard as an OBGYN to go be the only one, I think. And we had a problem, especially in Oklahoma, and I think it's the same problem in Arkansas. It is where labor and deliveries are closing down. I mean, it's kind of expensive to have a 24/7 labor and delivery staffed with appropriate people, anesthesia on call, OR crews on call for C-sections, and to have that one provider if you don't do a certain amount of deliveries. And so it's very hard, I think, for a rural community to, number one, attract a provider, but for a hospital system there to say this is financially viable for us. And that goes back to kind of reimbursement, how much you get for delivery or from Medicaid versus private insurance. And if it's in a rural community, patients may not have insurance at all. How much is it going to cost them to have a baby at that labor and delivery? So there's a few problems with access to care that go along with recruiting talent there. I remember leaving fellowship and going into private practice and deciding to come to Northwest Arkansas, and I had talked to several MFMs in the network of people, and they thought that's crazy. You don't leave academics. What's an MFM going to do in the community? And I just would love. Now they see my volume and what we have to do and what I see, and I'm like, it's. And we do telemedicine. I do telemedicine down to Fort Smith. My diabetic educators see people on their phones. We have an app they can use to do telemedicine visits. It doesn't have to be that you even sometimes physically be in the place, but I'm always looking for ways to extend that if I can't be physically somewhere.
And I agree with what you said. It is more difficult to recruit doctors in general to small rural areas. Like, Clarksville's struggled to recruit primary care and a lot of different specialties. And so one of the things that they do is we've reached out to all the different rural match programs. We've actually started having medical students come visit prior to them even knowing what they want to do in residency. So I think I think people hear small and they assume that means that we provide a lower level of care, or that we're incapable of providing quality care, and that's actually just not correct. I think we do really well on our quality measures compared to everyone else in the state, and we strive to, we're still held to a level of excellence. So I think by getting people into our communities where they can visit the hospitals and actually see the facilities, interact with the doctors. So I would say the gaps there, again, go back to education of what is it really like to practice in a small town? Because I will say, while it's challenging, it's very rewarding because you really know the people that you're taking care of. So it's a completely different way to practice medicine, but it's maybe the old, more traditional model that, it's not the same as how some people are being trained now. But when people are exposed to it, I feel like they're kind of shocked that they like it and that it's inviting. So we've had really good, response from medical students who have come to visit. So I think, again, education of what's out there, what's available, and trying not to put rural medicine in a negative light.
No, I think that's great. And I think, Dr. Champs, to your point, that we did used to have a role match, and OBGYN did used to be in that. And what we found is as my residents were graduating, there were not places for them to go. They may support the obstetrics and they could have some deliveries, but many of these smaller rural hospitals could not support the gynecology. So these brand new grads were losing a whole half of what they were trained to do in the gynecology. And so I think has led us to these discussions on these, expanding OB-GYN providers. And I think there's been tons of great discussions about family medicine OB, improving our midwife, numbers and creating a school. In you guys' opinion, what will be the challenges in kind of instigating these programs, and what can lead to success? How can we ensure that we expand this obstetrical workforce in a safe manner while still maintaining the integrity of the medicine?
I think we're, as in residency fellowship, we're kind of trained that this is how OB care does. You do this, you deliver here. Everybody has this defined role. I didn't have kind of this background. I've worked in different, kind of a different background where I wasn't just right through medicine through school. And you realize there's lots of different ways to kind of form a team. There's lots of different ways, or different people can transfer from one role to another. Things can be done. And of course in OB, it's, I think, risk stratification. Everybody is not always the highest risk. They can be pretty low risk. And that will take some rethinking of these kind of ingrained thoughts about this is the way it has to be to, well, this could be done this way. We can, being open to the creativity and not thinking that it's going to be a bad thing or unsafe, or if we expand coverage or give services in an area that may be underserved for low risk populations, things like that. That will require some openness from all providers, I think. That's important, especially when you kind of are, I wouldn't say in the middle of nowhere, but you're not in a central area with a huge academic medical center. That's a big deal to be able to have that team, be able to be flexible in how you're taking care of patients and be open to that, and that it's okay.
And there's a really good correlation to that, being open and being creative. It doesn't have to be the same black and white answer that it's been for the last decades in incorporating midwives, because a lot of physicians get hung up on the misconception that midwifery care is a lower standard of care, or that we are providing unsafe care. And that's just simply not true. We are able to work really, really well in that low risk realm and take a lot of that off of the OBGYN's plate, because, let's face it, OBGYNs are busy. And so in the realm of a midwife, I'm able to take that low risk piece, or even moderate risk, working collaboratively with a physician, off their plate and able to present a creative solution. And you can hire multiple midwives to one or two physicians, and you're able to build a flourishing practice. And so really approaching those creative solutions with an open mind is key.
I think that's great. And I also think, I think just getting, identifying the people who are willing to be collaborative and who are willing to be the mentor or the backup. And, some of the, hospital systems and payers need to be supporting those physicians that are going to be sort of the stopping point, so that they can really, we can build a flourishing collaborative practice where midwives and doctors are all working together, and it just, extends all of us to be able to serve more women.
I would agree with that, and I would also add that we need to have some really well thought out plans of what's going to take place when low risk becomes high risk, because I think all of us know that a lot of the complications that happen are unpredictable, and they're in low risk women, or what we consider low risk pregnancies. So I think having well thought out, really well defined plans of what do we do when things become complicated, as opposed to trying to figure that out on the back end, is also really important, because the more we're prepared, the better outcomes we're going to have.
And that's why, I mean, again, I think it's collaboration, right? We all of us want to be swimming in the same direction. And so I think, you know, I love the midwifery program that we've created at UAMS. Joni Arnell is in the back, and she has been instrumental in leading that. And I think it was built on mutual trust and respect, and we created what that looks like for our system, and we kind of help support each other. I think we've seen it in other places in the community where they've hired midwives, and 18 months later they've had to let them go because that was not supported, and it wasn't a collaborative effort. I guess just as some tips for the community, as we are looking to creating this midwife program, as we are creating these integrative issues into the hospital system, what has helped you be successful in Fort Smith?
So it's the understanding that the midwife role is different than a traditional APRN role. We don't always work regular, like 9 to 5 clinic hours. It's a very fluid role, and so having that clear plan and that clear understanding of what happens when, what happens next, is really instrumental. And understanding that we are approaching care from a nursing background. We are traditionally nursing trained prior to becoming midwives, and so we approach things differently than a physician would. And so really giving the midwives that you hire, that you trust and that you've built that relationship with, that breadth to do what they do and do it well, and trust them to say, like, hey, I'm out of my depth, this patient has now become high risk, this is where you need to intervene, is really key, and not putting us in little boxes and saying you have to function within this role, and if you don't function within this role and or you're not productive to a certain number in however many months, then it's time to go. Really being open and giving it time to grow.
I think that's huge. I'm going to switch gears just a second because I want to touch on something that's kind of, been talked about here today. And, I'm sitting on a panel with providers here, and I know not a single one of these providers went into medicine for not altruistic reasons. They're here to help people. They want to make a difference. But I think a resounding theme that we've heard is that quite often patients don't feel like they're heard, right? We feel like they're slipping through the cracks somehow, or some element of this communication is not happening. I would love to get y'all's perspective on why you think that perception is happening, and what, if anything, can we do, and what can the communities and hospitals do?
Well, I would say listening to the panel at lunch, I was a little disappointed that no one chose to talk to a patient that had a really great birth experience, because I do feel like there are a lot of good stories out there, and I think that we shouldn't focus completely on the negative stories, that we should also focus on some positive stories. And while it was a little bit doctor bashing slightly, as sitting there listening, I feel like also we could focus on some things that are being done well and try to bring some of those to light also, and to remember that we have, a lot of times not unlimited time to try to provide care, and sometimes our perspective is different. We're trying to provide safe care, and while we do want to make sure you have a complete understanding, sometimes we don't have unlimited time to do that. Unfortunately, in obstetrics, as all of us have said, things can go bad very quickly. And so while a lot of times we're trying to explain things, we might not do the best job, but I promise our primary focus is on the safety of the mom and the baby, and we're not sacrificing that. I mean, we may not always explain it as well as we could have if we had 2 hours versus 10 minutes, but we're really trying to do that as best we can.
Is what came to my mind too, in terms of providing, that just the time constraints that physicians and providers in general are faced with. I mean, there are so many things. As she said, we all went into this to help patients and to be there for patients and to make a difference. And then to kind of now have found ourselves in this medical system that requires us to, in this medical culture, I should say, that requires us to check boxes and do all of these little quality measures and things, all, well-intentioned for a greater good, but it is very sort of onerous in a day-to-day, in your day-to-day practice to have to, okay, you're here for your annual exam, and I've got to ask you, I've got to look at your blood pressure and your BMI, and these are all regular things, but in addition to the normal things and practicing medicine, we have to check all these other quality things off and all these forms and things that our office staff and us have to do, and so time is definitely, definitely a barrier for a lot of us. And then, just kind of how things used to be and how medicine is becoming. I think we all are still learning, and we're all human, and we're just, we're not robotic people providing, or robots providing care quite yet, but we all need to be focusing on patient-centered care, and I think that that's really where medicine is heading and needs to be heading, and especially women's health. I mean, social media is a huge driver of what women want in their healthcare and what they're expecting, and I think that's great in a way, because it brings the awareness of, really what people what women deserve, what people deserve is patient-centered care, and so we all need to be working towards that and hearing the patient and listening and providing the care that they're looking for as much as we can.
I thought about this a little bit as well. People come to me with, they've had a terrible past pregnancy experience. I don't know why I delivered my baby at 32 weeks. They said I was going to die, but I don't know why. I get asked that question a lot. Or they're referred to me because their baby has a defect, a heart defect, or a very, very abnormal ultrasound. So I've apprised myself of Google searches, ChatGPT. I know what they're going to Google. I know what TikTok's going to say. I know what a Facebook group's going to say. Why? Because that's unfortunately where patients or women kind of are going to go to. They don't have, I don't jokingly say this, but I was like, there's not going to be a huge group of friends that you're going to go talk to about their kid with tetralogy of Fallot. Or your group of friends that have a baby with trisomy 18. It's a lonely world to be in. And I don't have a lot of time in clinic, but I have little canned lectures. I have medical students that rotate with me, and I've got these weird little drawings that I have for diabetes, for hypertension, for preeclampsia. And, the placenta is like this creature that does crazy things to moms. And once they start to understand that, they're like, oh, this isn't me. It's not my baby. This is my placenta. It does different things at different points in my pregnancy. And I've kind of developed these little miniature lectures for everybody, because I realize that sometimes patients there's not a good place for them to learn about some of these complex things. And I know that they'll Google it before they come see me, because why wouldn't I would? I'm going to Google it and see what I can, because I know no one else knew about it. But it's a challenge when you don't have that much time. I've gotten good at that, but it changes every day. But it is a challenge. I think we all face that all the time. If anybody's ever had a patient that has talked to me about diabetes and gone back to your clinic, just have them ask about my hotel room vacation analogy about diabetes. But there's a talk for that. There's a talk for everything. So.
I would also say that I feel like we have a really good opportunity right now to kind of heal the relationship between all of the medical care providers, and that we are all ultimately on the same team. We all want healthy mom, healthy baby. And I think embracing the idea that the physician's not the enemy, the midwife's not the enemy, the doula's not the enemy, somehow finding a way to come together and understand everybody has a role, and probably we can utilize the education of every single person in an effective way. We just have to figure out a way to be able to do that where the patient understands that everybody's on the same team. So I think, what we don't want to get into is one provider saying, well, they're over-medicalizing your pregnancy, and one provider saying they're under-medicalizing your pregnancy. we're on the same team. And I think we have to figure out an effective way to do better with that. I don't know what the answer is exactly, but I think awareness certainly is a great place to start, and then starting to heal those relationships and becoming a unified team.
No, I think conversations such as this are exactly how we kind of start breaking down those barriers and seeing where the other person's coming from. And I know, the panelists talked a lot about time constraints, and just as a perspective for everyone in the community, in this room, at the beginning of COVID, we had 39 delivering hospitals. Shortly after, it fell to 37, and we now have 35. So that is access points that are gone. That is more patients being funneled into the existing access points, with more people retiring and no new providers coming into the system. So tit for tat, each provider is seeing more and more and less healthy individuals because we're not getting that preventative care on the front end of their pregnancies. So anyway, great discussion. All right, it looks like we have about 10 minutes, and I want to we've talked about not having a silver bullet, but say we did have a silver bullet. If we had unlimited resources and the sky was the limit, what is one thing you would like to see done? And I would love to hear from all of y'all.
I think, my silver bullet would be if I had all the money in the world, everybody would have childbirth or prenatal education classes as part of their, either where they're delivering or through their clinic that they're delivering with. That starts fairly early, and everybody funnels through and everybody gets the same information and opportunities to say, okay, well, this is where I deviate and how does this apply to me? And, but childbirth education is hard to implement and it's expensive to implement. So that would be mine.
I agree that the childbirth education is super, super important. The other thing is, another kind of to segue onto the backside of that, is postpartum care and support. I was telling Nirvana and Shannon last night that a friend of mine had her baby in the Netherlands, and in the Netherlands they have it's a postpartum support person called a Kromzorg, and your Kromzorg basically is they're not necessarily medically trained, but they basically are dedicated to each patient for 8 to 10 days after that patient has their baby. They come to their house, they do weight checks on the newborn, they can assist the mother with breastfeeding, but they can also do things like help them do laundry and cook a meal for them, and basically provide some support that sometimes I feel like is maybe even better from an independent person than from a family member. Sometimes a family member gets a little too focused on, they just want to hold the baby, but they're not, whereas that needs to be what the mom is doing. And so this person that is not related to you, I feel like is really a great source of support. And my friend who had her baby over there said it was like the most amazing experience ever. And that's obviously would be a super expensive process, but I think the postpartum support is still greatly lacking in our country, just in general. Postpartum, leave, there's so many things involving postpartum care that's definitely lacking.
If I had all the money in the world and there was no limit, I would, I think, start even before people are pregnant, women are pregnant, and I would actually just revamp our whole food system and industry in this country, because our young kids are eating so much processed garbage food, and it's everywhere, even in the hospitals. Your hospital plate that comes, or as healthy as we try to make our food, we just I can't even, everyone would be eating homegrown veggies from their backyard and have cows and chickens out back, because we need to do a better job educating our kids from the time that they're little itty bitty, and we all need more vegetables and healthy, components to our diets, because I think that the root of a lot of disease, a lot of, chronic disease is unhealthy diet and also unhealthy habits. We need to teach our children and teach our young people that mindfulness mindfulness and meditation and all the yoga and exercise, moving your body every day. These are healthy habits. These are lifelong habits that will serve you well through childhood, adolescence, pregnancy, postpartum, and your whole life. And so we really need to focus on that, I think, as a nation and as a country and as healthcare providers as well.
Earlier, we talked about, or you had mentioned having access to prenatal care. I think two things. It would be access to prenatal care early enough before you have to wait for insurance to kick in or to get Medicaid to where it's halfway through your pregnancy, and you don't know how much it's going to cost. That's a huge barrier for a lot of patients, and it's a money issue. So if you had all the money in the world, take that away and be like, this is going to be covered. We'll get this insurance done, but otherwise you don't have to worry about this. Get your prenatal care, we'll worry about it later. That could be that's a financial issue. And then being able to have access to a place to go that's not 3 or 4 hours from your home for, being able to see a provider or deliver your baby, but also have the safety nets if you have to go somewhere that I'm not gonna be left alone, or my poor doctor is gonna have to find 5 different places that someone will accept me to go. I think for a patient, they can sense that frustration, and that would be great if we could have more access points to care. That doesn't mean they always would be delivering there, but more access points to care to where they can go to get delivered, get to the right direction. That could be physical building spaces, virtual spaces, just so it wasn't so mysterious where you go for information and how to get answers. Just the thought.
I agree with all of that. Education is a huge thing, and you pointed out prenatal education. I also think pregnancy and lactation education that starts well before people are delivering. I think we focus a lot about in the last couple of weeks of pregnancy about talking about lactation and afterwards, but particularly like in my county, in my hospital, we have a big hole where we have currently we don't have a certified lactation consultant, so we do access the Baptist health system frequently, which has been really helpful. But I think if we had more people being encouraged to go into those fields that had more incentives and those programs were easier to get through. It's the APN that works in my clinic looked at becoming a certified prenatal education provider and also a lactation consultant, and it's really expensive to do those things. And so I think making those things more accessible, both so there are more people out there that can provide those services, but making those free to patients or little cost, I think that would be helpful. But also, I think social work is a big hole in a lot of the rural communities as well. And we've already touched on transportation. I think if I hear that over and over and over in my practice where, why did you not come to your appointment? Well, I didn't have a ride. Or I need to go see the MFM and they recommended that I come do once weekly Dopplers, but I can't drive to Fort Smith every week. I don't have good tires on my car. That's an actual patient that happened recently. And so what ends up happening is then we provide the highest level of services that our hospital provides, but we still know that your care would be better. And so we've got to figure out a way when people have transportation issues or, difficulty, we can access them, we can make the appointment, but if we can't get the patient to the appointment, that's a problem. So again, that all goes back to funding, but if I was given all the money in the world, social work, access to subspecialists, and education. Yeah.
No, I think that's great. I can either ask one more question. I don't know who's here. Okay. Yes, I can either ask one question or go into, but go ahead if you would. Yeah. No. I will do a takeaway. So is the question like if we had half the money we have now, what would we do? Oh, Yeah. Well, I mean, I think if we go back to Heartland's economic impact, I mean, I think there's some huge takeaways with regards to some of the things that are big riders in those. And I kind of jotted down a few. He said 4 of the primary drivers in the economic impact of maternal health, number 1 was unplanned pregnancies, which we know 50 to 60% of all pregnancies in our state are unplanned. Mental health challenges and substance abuse, metabolic syndrome, including obesity, hypertension, diabetes, and the lack of available maternal health resources. I mean, anything y'all would add to that with regards to how would we pivot with half the resources?
One thing that all my patients have is a cell phone. All right. And so, again, going back to you can tell I'm highly technologically bent here, but usefulness of that for access to information, access to a provider, even if you can't get in your car and drive somewhere. I've built iPhone apps. They're not extremely expensive to build, and everybody could have access to that. You could do that for a quarter, a tenth of the amount of money that you could spend on trying to get to an office visit, the bill for the office visit, you name it, the expenses of all of that going into play with being able to access things through an electronic platform. And specifically for me, where just knowledge and education and counseling on where to go is a big part of it. Ultrasound is the other big part, but getting them there. I mean, we also are working on, we scan in Fort Smith, and then I read remotely. I can scan from anywhere if I have a sonographer there. But the technology component of it is very poorly leveraged in healthcare, and it's not just obstetrics where we could use it better for a lot cheaper, yeah.
Well, I'll ask one more question, just because we have such amazing legislators in the room today that have been so attentive to a lot of the needs. And I think, like they reiterated on the panel right before us, they need ideas, right? I mean, they are not in the healthcare space in the way that every individual is very different. And so if there were some ideas on changes that you would like to see with regards to policy, what would they be?
Every patient would have everything covered for their, if they're not privately insured, if they're on Medicaid, and especially unborn child Medicaid. I don't know if all of you know, but if a patient is not a citizen of the United States, if they're Marshallese or if they've recently immigrated, then what they get, even if a lot of Hispanics fall into this category too, from if they've recently immigrated. They get what's called unborn child Medicaid. So that covers what's medically absolutely necessary for their pregnancy, but nothing outside of that. So no postpartum birth control, no, let's say they have an abnormal pap smear that is done as a part of the prenatal screening, the routine panel, we get a pap. Well, if it's abnormal and they need a procedure to take a look at the cervix and do biopsies and prevent them from getting cervical cancer, it's not covered. So they either can't get it or they have to pay out of pocket. And that's not achievable for a lot of our patients. They can't pay $700 for a colposcopy on top of having a pregnancy and going to have another baby added to their household. So I think we'd have better coverage just for kind of all around prenatal and postpartum. Kind of like, California has a lot of really good programs that those patients are covered throughout, no matter their status in terms of legal residency or citizenship or whatever.
I think also Medicaid reimbursement is going to have to somewhat equalize to insurance reimbursement in order for us to truly provide quality care. A lot of the highest risk patients that we take care of are our Medicaid patients, and a global fee, Larry Shackelford showed me this earlier today, a global fee for Medicaid pays $1,200. So that's a reimbursement. So that's expecting us to provide 10 prenatal visits, as we discussed, is the optimal number of prenatal visits. 10 prenatal visits, ultrasound, a delivery, and postpartum care. I mean, most of us pay way more than that to get to the person who cuts our hair, to our dog groomer, to multiple other things. And so it is going to be difficult for patients to receive optimal care in that kind of reimbursement setting. It's just, it's very difficult. I mean, we have to pay our nurses, we have to pay our clinic staff, we have to pay all of those things, and so it's very hard when there's such a discrepancy in what is getting paid for.
I would agree with that and add risk stratification. So if you're taking care of what we've stratified as a low-risk patient that only needs 10 visits and a typical delivery, that to be one reimbursement rate versus a morbidly obese type 2 diabetic who's over the age of 35
And then
with
2
chronic
prior
hypertension,
C-sections.
which is realistically the majority of the patients that we're taking care of, who needs 22 or 25 visits. They need twice weekly antenatal testing. They need so many more resources. And functionally, we are providing those resources, but we're doing it for free because we're still going to provide the level of care that they need. We're not going to not have someone come get a non-stress test if they need it. We're just going to eat that on the back end. But there's a point where you can only do that for so long. So I think to put up, the graphic that was presented by Heartland, that these counties have very few providers accepting Medicaid, there's a reason for that. And it's because you have to see 3 private insurance patients or 3 Medicaid patients to equal 1 private insurance patient. And we're all doing it. And luckily for me, I'm hospital owned, so it affects me a little bit differently because the way I get paid is differently. But for people who are out there in private practice who are not, it's much different for them. And so I think that's a barrier to care as well, particularly for women that have Medicaid, because people are more reluctant to take them, and particularly take them if they're high risk, because the amount of time that it takes to give that person quality care far outweighs what you're reimbursed for that.
Which then creates a larger access issue as a whole. But anyway, well, thank you all. I think I've run out of time. Is that right? Okay. Do you want me to, any other questions? I bet we could take one more question. Okay.
The other thing that is, I listened to the women's stories this morning, and as a nurse practitioner and one who's married and a mother to physicians, I cringed a little bit too. I mean, I just felt so sad that that was the experience of these women. But I'm wondering, in national organizations, we've talked a lot about centering pregnancy and centering parenting. Are you guys doing that? Is it something that you're finding effective? Is that a way to pull more people in so that they are feeling heard? I'm not sure it has to be from the physician necessarily. As a nurse practitioner, I feel like that's a nurse's job a lot. But it seems, at least nationally, the statistics are saying that centering is helping with the patients being heard. And I'm just wondering if that's something that you guys are doing.
I'm glad you brought that up, because that was almost my answer. How can we do more with less money? If we cut our costs or cut our reimbursement, cut our dollars by 50%. But Willow Creek had a while back, right before COVID, we had done. There's different, group prenatal. The March of Dimes is one, centering is one, and I think that's a great idea to expand access. We kind of started it right as COVID was coming up, and then it sort of fell by the wayside, but we're going to get back into that group prenatal model, and I think it's a great way to really be able to reach more patients with not each of them needs to have a 15-minute visit with a provider. They can all come together, and then built in that is a sort of a support group, a support network for these women as they embark on this pregnancy and motherhood journey. So I think that is something that we all need to sort of make more feasible for, like, how do we make this work for our practices? And I know UAMS has.
Yeah, in 2017, UAMS started centering for pregnancy, and it was highly successful. COVID definitely put a damper on that. And now I think we've pivoted more to kind of a mobile centering and taking it into the Delta and other other areas where there may be these healthcare deserts, and how can we team up with some of the physicians in those areas such that they know that we're not necessarily there to impinge on their medical decision, but we can provide some valuable education and some resources, because truly it's 2 hours of education, which is just priceless in this day.
A lot of time actually too, as a provider, if I have to tell the same thing at their 32-week visit to 12 patients that day, it would be great if they could just get all that from a nurse practitioner or a midwife who could like really delve into it and take more time. And I think that's a really good option.
And that social support that you create with your group that you run through is huge, because especially if you have not a first-time mom with a group of first-time moms, she may have navigated the community resource systems that we've talked about and be like, oh, I can help you. Let's do this application. You qualify for this. And so it really brings women together to not only provide that clinical support and help on the provider side, but on the social support side, where you have a group of women experiencing the same things who've potentially navigated it before.
Well, great.
Thank you.
Well, thank you guys all for the opportunity.